Hi guys, welcome back to Codemaster Coach, your medical coding tutor. Okay guys, we're continuing our review of the official 2025 ICD-10-CM coding guidelines. And this week we are down to chapter 19 and we're at F. F is on adult and child abuse, neglect, and other maltreatment. And I'm starting with the note that says, look for, was it a confirmed case or a suspected case of abuse? That's our first goal. Was the abuse confirmed or suspected? If confirmed, you're going to be in the T74 category. But if suspected, you're in the T76 category. And again, if confirmed, add an external cause codes. Add those external cause codes to give greater information about what occurred. So when you're adding these external cause codes, you should be between X92 and Y09. And then when identifying the perpetrator of this abuse, it's going to be at category code Y07. However, if suspected, do not code external cause or identify a perpetrator. And when you do use your external cause coding, the first external cause code identifies the actual assault, what type of abuse occurred. And then the second code identifies the perpetrator who committed the abuse, if known. But again, this external cause coding is only completed for confirmed cases. So that's why it's so important for you to determine, was the abuse confirmed or suspected? Now let me go back to our guidelines, make sure we're covering everything here. Sequence first the appropriate codes from categories T74 for adult and child abuse, neglect, and other maltreatment confirmed, or T76 for suspected. If the documentation in the medical record states that the abuse or neglect it is coded as confirmed. So if your documentation states it, we confirm it. But it is coded as suspected if it is documented as suspected. For cases of confirmed abuse or neglect, an external cause code from the assault section, X92 through Y09, should be added to identify the cause of any physical injuries. The perpetrator code Y07 should be added when the perpetrator of the abuse is known. And then for suspected cases of abuse or neglect, do not report external cause or perpetrator codes. If a suspected case of abuse, neglect, or mistreatment is ruled out during an encounter, then code Z04.71, encounter for examination and other observation following alleged physical adult abuse, ruled out, or code Z04.72, encounter for examination and observation following alleged child physical abuse, ruled out, should be used, and not a code from T76. If a suspected case of alleged rape or sexual abuse is ruled out during an encounter, code Z04.41, encounter for examination and observation following alleged adult rape, or code Z04.42, encounter for examination and observation following alleged child rape, should be used, and not a code from T76. If a suspected case of forced sexual exploitation or forced labor exploitation is ruled out during an encounter, code Z04.81, encounter for examination and observation of victim following forced sexual exploitation, or code Z04.82, encounter for examination and observation of victim following forced labor exploitation, should be used and not a code from T76. So let me go back to my outline. And I'm down here. You know how you have your little cheat sheets with your codes on it? So what I did is, just like I did the confirmed T74, suspected T76, well, for these suspected and ruled out, past tense, it's been ruled out, abuse, neglect or mistreatment, adult physical abuse, I've got Z04.71. And for suspected and ruled, past tense, out, abuse, neglect, or mistreatment, child physical abuse is Z04.72. And then for suspected and ruled out adult rape abuse, Z04.41. And suspected and ruled out child rape abuse, Z04.42. And it even goes on, suspected and ruled out forced sexual exploitation, Z04.81, and suspected and ruled out forced labor exploitation is Z04.82. But just from looking at my, what I call my little cheat sheet here, notice for confirmed and suspected is T74 and T76, but when it goes from confirmed, suspected to ruled out, it becomes a Z code because it's not there. Think about, remember your Z codes. Our true diagnoses codes are A through U. It used to say T, but now U with COVID and vaping disorders now, with our U category. So any codes between A to U are actual diagnoses codes. And then when we get into our Z codes, remember, those are status, usually status codes, like your status allergic to penicillin, status you're so many weeks pregnant. So when it gets to suspected and ruled out, then that means that diagnosis isn't there. It's got to be a Z code. So I made my little cheat sheet with my little codes for suspected and ruled out, whether it's child physical abuse, adult physical abuse, adult rape abuse, child rape abuse, and then sexual exploitation and labor exploitation. Notice they're all Z codes because they've been ruled out. They no longer exist. Okay? All right, we're down to complications of care. Complications of care. Make sure that's the next thing. Yep, we're down to complications of care on our guidelines. And I made some notes that I wanted to make sure I cover. I've got a purple note here. You know my purple notes are Codemaster Coach notes, which means it's my little touch. And I put on here, as I was learning medical coding, I kept hearing the terms CCs. CCs, are those CCs? But I didn't know what that meant. Well, I have since learned that CCs stand for complications and comorbidity. So what is the difference between a complication and a comorbidity? Well, comorbidity is an additional diagnosis that the patient has in addition to the principal diagnoses. And these comorbidities must be monitored while treating the patient for the principal diagnoses. Therefore, these comorbidities will be additional diagnoses that we will be coding along with the principal diagnoses, because these are conditions that we'll be treating along with the principal diagnoses. But the key here is a complication. A complication is just that. It's a complication. Something went wrong. To me, when I think of complication, I think of a patient coming in to have surgery, whether it's an appendectomy or whatever. While the patient's on the operating table, and you always hear, oh, patient went into cardiac arrest, that's a complication. Something went wrong. A complication, if a complication is noted, it must show a documented relationship between the condition and the care. Keep that in mind. If it's a complication, there must show some kind of documentation of a relationship between the complication and the care. And due to possible legal ramifications, medical coders should never assume a complication. If it doesn't say complication, even though you think it is a complication as the coder, don't code it as a complication. Make sure the complication is documented as a complication by your provider. All right, so first thing it says is refer to the guidelines for general guidelines for complications of care. So let's see what the guidelines say. It just says documentation of complication of care. See section 1B16 for information on documentation of complication of care. So I think I wrote that guideline out. Right here, it just says code assignment is based on the provider's documentation of the relationship between the condition and the care or procedure unless otherwise instructed by the classification. The guideline extends to any complications of care regardless of the chapter the code is located in. It is important to note that not all conditions that occur during or following medical care or surgery are classified as complications. There must be a cause and effect relationship between the care provided and the condition, and the documentation must support that the condition is clinically significant. It is not necessary for the provider to explicitly document the term complication. For example, if the condition alters the course of the surgery as documented in the operative report, then it would be appropriate to report a complication code. So query the provider for clarification if the documentation is not clear as to the relationship between the condition and the care or procedure. So your guideline clearly states just that a complication is not necessarily a complication just because something occurred, but it needs to be documented as a complication. And then we're down to 2, pain due to medical devices. It says first refer to the guideline. So let's go to the guideline. Pain associated with devices, implants, or grafts left in a surgical site, for example, painful hip prosthesis, is assigned to the appropriate code or codes found in Chapter 19 for injury, poisoning, and certain other consequences of external causes. Specific codes for pain due to medical devices are found in the T code section of the ICD-10-CM. And then use an additional code or codes from category G89 to identify acute or chronic pain due to presence of the device, implant, or graft. And it will be either G89.18 or G89.28. So let's make sure I covered everything at 2. Note code from Chapter 19 that begins with either an S or a T plus the G code. Yep. So identify the pain, where the pain is for the medical device, and then add your chronic or acute pain code to that. All right, we're down to 3, transplant complication. And it starts at A, transplant complications other than kidney. So at 3, transplant complications other than kidney, codes under category T86, complications of transplanted organs and tissues, are for the use for both complications and rejection of transplanted organs. A transplant complication code is only assigned if the complication affects the function of the transplanted organ. 2 codes are required to fully describe a transplant complication. The appropriate code from category T86 for complication of a transplanted organ and tissue, and a secondary code that identifies what the complication is. Pre-existing conditions or conditions that develop after the transplant are not coded as complications unless they affect the function of the transplanted organ. So again, that's the key. If it affects the function of the transplanted organ. All right, let me make sure I've got anything on my notes for A. Just a note that says Two codes are required. The T86 code first, and then the complication code is only assigned if the complication affects the function of the transplanted organ. If so, then assign a code for the complication. All right, we're down to B, kidney transplant complications. Let's go to our guidelines. Patients who have undergone kidney transplant may still have some form of chronic kidney disease because the kidney transplant may not fully restore kidney function. Code T86.1 should be assigned for documented complications of a kidney transplant, such as transplant failure or rejection or other transplant complications. Code T86.1 should not be assigned for post-kidney transplant patients who have chronic kidney disease unless a transplant complication, such as a transplant failure or rejection, is documented. And if the documentation is unclear as to whether the patient has a complication of the transplant, then query the provider. Conditions that affect the function of the transplanted kidney, other than chronic kidney disease, should be assigned a code from subcategory T86.1, complications of transplanted organ, kidney, and a secondary code that identifies the complication itself. For patients with chronic kidney disease following a kidney transplant, but who do not have a complication such as failure or rejection, see Section 1C14, chronic kidney disease and kidney transplant status. Make sure that's everything under 3. Yeah, just remember to refer to that Section 1C14. And number 4, complication codes that include the external cause. Let's go to the guidelines. As with certain other T codes, some of the complications of care codes have the external cause included in the code. The code includes the nature of the complication as well as the type of procedure that caused the complication. So no external cause code indicating the type of procedure is necessary for these codes. So it's straight from the guidelines. It explains it. If that code includes the external cause, you don't need an additional external cause code from the external cause index because it's already included in the code. It already identifies what the complication is. Now, number 5 says complications of care codes within the body system chapters. So let's see what 5 says. Intraoperative and post-procedural complication codes are found within the body system chapters with codes specific to the organs and structures of that body system. These codes should be sequenced first, followed by a code or codes for the specific complication, if applicable. Complication codes from the body system chapters should be assigned for intraoperative and post-procedural complications. For example, the appropriate complication code from Chapter 9 would be assigned for vascular intraoperative or post-procedural complication, unless the complication is specifically indexed to a T code in Chapter 19. And you'll learn your S's and your T's are external or justify the use of external cause codes because the T codes identify the injury. All right, let's see if I'm covering everything from 5. Yep, 5 just says complications of care codes within the body system chapters. So it's straight from that guideline. It's clearly stated. All right, guys, next week we're at Chapter 20 on external causes of morbidity. And these codes are V00 through Y99. We're wrapping it up. We're getting close to the end, guys. Remember, I said the actual diagnoses codes usually start with an A or anywhere from A through U. But when we get to the V's, we're getting into external cause coding. All right, guys, that's it for this week. I'll see you the next time. Thanks.